I don't know.
What's up? So what software do you use to tweet?
No.
All right, good evening, everyone. I don't have a mic.
Yeah.
Good evening, everyone. Perfect. Thank you very much for taking your Friday evening to be with us tonight. It's the ecosystem panel, and I'll tell you a little bit about what the ecosystem is. Essentially, our goal is to bring together people interested in healthcare across the Yale campus for events such as this one, events that are very prominent and important to improving our healthcare system. So tonight we'll be talking about data and how to use it to improve our system. And we have an outstanding group of panelists with us, really. We're going to be learning a lot from them, and I'm really excited, and I hope you can engage with them as well in your questions. We've got Sarah Constantine, we've got Dr. Paul Taheri, we've got Dick Foster, we have Dr. Harlan Krumholz, and we have Zach Cooper. They are the leaders in this field and certainly shape the way that our American healthcare system is operating. So I'm really excited to learn from them, and thank you to them for taking the time to be with us and to share their thoughts. Dick Foster will be moderating for us, and we will, after this discussion, then move on to the Beinecke Terrace for a mix and mingle and a reception. So you can actually meet and greet our speakers as well. Thank you.
There will be no rain
Yeah.
at 7 o'clock.
No.
That's
And
all been taken care of.
I took care of that.
Right, okay.
Don't worry.
That's great. Well, good afternoon, good evening. It's wonderful to see all of you here in the expanding healthcare community at Yale. It's really great. We do have a terrific panel here tonight with people of all kinds of experience. I have the best possible job because it's up to me to ask the questions. I don't have to answer anything. So, as you know, faculty members love to be on that side of the table, which means we don't have any real responsibility. So we'll do that. What I'm going to ask each of the panel members to do is speak for 2 or 3 minutes just to give a brief introduction to themselves and their point of view, and then we'll come back and I will address some questions to each of them for about 15 or 20 minutes. Harlan is here tweeting simultaneously, so be careful. You're all you'll be worldwide in seconds.
It's a judge of the panel to how many tweetable moments there are.
And then we'll open it up to questions from you for the last 20 minutes or so. Questions are things that are generally sentences, one sentence. They have a period at the end, and you're allowed 1 semicolon. And they have a question mark at the end, actually.
Yeah, exactly. That's the one. The one with the periods that you have to worry about.
I was an engineer here, so I'm still catching up. So we begin with Sarah. Do you want to tell us a little bit about you and your perspectives?
So I'm a graduate student getting my PhD in math here at Yale. I'm also the director of research at a medical research startup named MetaMed that's using some data techniques to do personalized medical research for individuals. Sort of my perspective on healthcare is that we are entering a quantitative revolution, and we can make healthcare a lot more empirical by using the new technologies available. The third leading cause of death in America is the iatrogenic risk. That is variously medical error, misdiagnosis, complications, nosocomial infections, harm that is a result of mistakes in medicine itself. You can reduce that probably by looking empirically more at what works, what doesn't, and using the wealth of information that patients generate throughout their stay at hospital or throughout their experience as patients. But that comes with responsibility to be very precise about which metrics we use. Big data also offers endless opportunities to mislead with statistics as well as illuminate.
Great. Paul.
Well, thank you, Dick. So I'm Paul.
I was just going to say, Paul runs the Yale Medical Group, which is the physician practice here that some of you are probably familiar with.
Right. So that's sort of my day job. Periodically at night, just so you know, I'm still a clinician. I take trauma calls, so I'm actually a general surgeon. So don't get in a car accident or anything else. Otherwise, you will see me in a different look. So his responsibility for the medical group is sort of running the business of the healthcare delivery for the physicians. So that is sort of my day job. And it really encompasses kind of the operations and finances of the clinical delivery. So we, like many people, have enormous data needs, and I will tell you the reality of it is, because I'm a pragmatist, is the data needs fall far short. What we get is not anywhere near what we need. So I'm hoping to learn something tonight.
Great. So Harlan Krumholz is one of the most distinguished and most insightful analysts of big data in the United States, and certainly has a long history. And many people think of him as the architect of many of the federal programs and how we think about data and its use.
Thanks. I'm a cardiologist, and as Dick said, we've done a lot of work on federal programs and quality measurement and a whole wide variety of things. So here's the thing I think about big data. Medicine really at its roots is hardly implementing any sort of smart strategies that acknowledge the individual differences of patients, customize treatments, understand the comparative effectiveness of the options that people have placed in front of them. The clinical research enterprise as it currently exists is wholly inadequate to keep up with the information needs of patients and doctors and policymakers and administrators and managers. And in part, we're waste the most valued resource in the healthcare system every day, which is the actual experience that patients have with their doctors. So one way of conceptualizing it is, it's as if we're doing what we call N-of-1 trials. There's an experience between a patient and a doctor, something happens, the decisions are made, outcomes accrue, and we throw them away. So we run all these experiments every day, in essence, but we don't learn anything from them. We are extraordinarily inefficient in trying to harvest that. And in terms of what the future looks like, another way to think about this, people talk about data mining and machine learning. I think it's less about mining and more about industrial farming. And the question is, how can we organize the data as it exists and accumulate it in real time in the course of the care that's being delivered so that we can reliably and accurately harvest knowledge that can be fed back into the system to improve the care for the very next person and then to teach the next person after that. And we are really practicing medicine now as they did primarily in the 1960s and 50s. We haven't fundamentally shifted, and we aren't equipping people with the power of the knowledge that we could have. And I think that this is a turning point. Both we have the increasing computational ability to do it, data will increasingly improve. But just as a final parting shot to give you some sense of this, if I asked you to think about what percent of the articles in our major journals reflect novel analytic techniques applied to massive data collections in JAMA, New England Journal, in Lancet. If I ask you what percent of the presentations at our national research meetings are providing insights about this, if I asked you what percent of the time in programs that are training scientists for the future, clinical research scientists for the future, are dedicated to these kind of tasks, you'd be right if you said just about zero. Just about zero. So when you look all around you, you see companies with ideas about advanced analytics adopting novel methods, and governments who seek to yield information from large troves of data applying advanced analytic strategies. You look in Lancet, New England Journal, JAMA, you look in anywhere in the medical research, it's zero. So that doesn't mean there aren't companies that are doing it at the periphery, but in the central research enterprise, it's currently absent. And this is something which needs to be addressed.
Zach Cooper, who has just come to Yale, just being in the last year or so. And prior to that, he has great experience with the National Health Service in the UK. Wrote many of the policy papers for the Prime Minister while he was there, and is here to do large data analysis on healthcare.
Well, thanks, Dick, and thanks for having me. Yeah, so I'm an economist here, assistant professor in the Department of Health Policy and then in the Department of Economics. And a lot of what I think about is sort of similar to Harlan, which is how can we, I think, provide empirical answers to what are very, very challenging policy questions. So how can we take the data that we have to answer really, really burning questions like why is healthcare becoming so much more expensive? And so I think it's worth pausing for a second to think why we're here and why we're talking about big data. And I think the first reason is just this massive explosion in our ability to collect data itself. So I was thinking about my jawbone on the way over here. This is sort of pedometer that's measuring how much I walk and how much I sleep. We think about the devices that are in your ICUs that are spitting out gigabytes of data a day on different patients. So one is just the availability of data. I think one is the drop in costs in how to store it. So that is the sheer reduction in how much it costs to house all of this data. And then the drop in cost in analysis, that we now have the processors that are available. And it's sort of worth thinking for a second about the size of the data that's available. I was sort of blown away thinking about this earlier today. This 150 exabytes. Anyone know what an exabyte is? I had to Google it. So 150 exabytes of healthcare data in the US. So 5 exabytes would easily, so it's 10 to the 18th gigabytes, so it would easily contain all of the words ever spoken by people in the history of time. Okay, and we have about, 30 times that in healthcare data in the US alone. So Kaiser itself is estimated to have somewhere between 26 and 45 petabytes, okay, which in and of itself is about 4,500 times the amount of data held by the national, by the Libraries of Congress. And so I think one of the why we reduce healthcare spending is I think the core 4 challenges that we face are questions that can be answered with big data. And I think the first is, how do we predict risk? Okay, so how do we identify who is going to get sick and intervene earlier? I think the second is doing a much better job understanding what quality looks like. Okay, so it's sort of ironic that via TripAdvisor, I knew more about the hotel that I stayed in last week in Los Angeles than about the quality of medical care that's being offered in most hospitals. And so I think big data can inform that. I think the third is matching. And it's matching patients with their providers, so we know where to go to get the best outcomes. And I think second is matching patients with the best treatments. So it's rather than getting the average treatment effect, it's getting the treatment for that individual. And then I think the fourth is sort of this bookkeeping, which is slightly more where I'm interested. Where does the money flow? We spend $3 trillion a year in the US. Where is this money going around the system? Where is it bleeding out? What represents value and what doesn't? And I think big data can inform all 4 of those components.
Right. So let me drill down one level, Paul, and ask you the question. As a user of big data,
Well, I think in the actual clinical setting, probably radiology and laboratory are the biggest consumers and generators of data. But to get a little bit to what Harlan and Zach were sort of getting to, it's very hard to get these big chunks of data into the clinical realm to make them useful at point of care. That's I think one of the single biggest problems. So we have tons of data about antimicrobials and resistance patterns in ICUs, yet getting that to the bedside is very difficult. And if you marry that with cost data, physicians would and could and should make better, more informed decisions. But today, it just is not a practical reality.
So Harlan, you've talked about this before. It's one thing to gather data, analyze data. It's another thing to have physician practice change as a result of that data. Where do we stand on that now, given what Paul has just said?
Well, we're nowhere. I mean, I think I would have thought your answer would have been, actually, we're not using big data analytics at all. I mean, it gets down to, the question, what is big data and how can you use it? But we have large data collections. For people who are expert, actually, they're not so large unless you include the imaging data, because most of what we consider to be large in medicine actually isn't so large. But we're not using any sort of novel analytics in everyday practice. And when you say, I do agree with you, these are complex interventions. So the first step is, can you get the right data and can you apply the right analysis to produce the knowledge? But we've got generations of doctors who are ill prepared for this, who are taught in a deductive reasoning framework around understanding mechanism and then making inferences about how that's likely to affect the person in front of them. And we're not trained in the idea that we need to have the accountability of understanding actually what does the empiric data show us about what's really being achieved, recognizing that the real world is much more complex than the simplistic mechanistic models we have in our head, which are largely biological. Because we really understand healthcare outcomes are probably an interaction of biological effects and contextual effects that come from the environment, come from individuals' behaviors, come from the place where they're getting the care and all the layers of variation that's occurring there. And so we haven't prepared people to think about that results-based accountability, that we actually need to derive insights inductively from data and then go back to thinking about mechanism that way. And so when you think about behavior change, you've got generations of doctors who think they know the answer because of their simplistic models of mechanism that they learned in pathophysiology in their classes. And they weren't taught to align deductive and inductive reasoning in a way that would layer into a preparation to say, my performance has got to be measured on my results. And I've then got to put that back in the framework of understanding what's the underlying root mechanism of the results I'm getting, and then how do I continue to spiral that up to improve.
Sarah, you're involved in a lot of this on the hands-on basis, analyzing the data. And so give us your perspective. What are the most advanced applications you're seeing, and how well are they working? And should we take solace from that, or should we be depressed?
So a couple good examples from the experimental literature are risk prediction models. So there are simple risk prediction models that have been around for decades and are used in emergency rooms, and they work, and there's ample evidence that they work better than unaided clinician intuition. That's how we predict heart disease. That's how we triage people in emergency rooms. It's completely standard. You can actually get even better accuracy often when you use raw data. Things like you actually scan in images and you use plain old machine learning to say, okay, these are the people with a lesion or some kind of problem. These are the people who are healthy, and automatically identify sick from healthy. That gives you accuracies 95, 99%. EKGs, the raw and high dimensional data sometimes gives you even more accurate results than the models that have a few variables, and it's a linear combination of these risk factors, which is telling you how bad off you are. In terms of applications in hospitals, there's much less of that. And my impression is that it's largely an implementation problem. You simply can't get doctors to do something that will interfere with their routine and take up their time and force them to do data entry and just not work with the flow of the hospital and the hospital's IT. That's never going to be practical. And I think there have been a few successful examples of clinical decision support working well, but partially it's just been limited by the fact that it has never been well integrated in hospitals across the country.
So Zach, picking up on that, give us a little perspective from the other side of the pond. Where do they stand relative to where do we stand? What are the best uses? Are we ahead? Are we behind?
Well, so I think the best use there is probably using data to inform how they're paying physicians. So in England, they introduced something called the Quality Outcomes Framework, which is essentially a pay-for-performance program for your internists. And basically what it was if you followed I think it made 25% of internists' salaries available whether or not they achieved certain clinical outcomes. And what that required then was entering the data on whether or not you hit those measures. And so I think it was using that and then linking the outcomes to the payments. I think the fundamental problem in the US healthcare system right now is that we have a system that pays for quantity and not paying for, that doesn't pay for quality. So that is, you get more from doing more, not by doing better. And I think what England managed to do in a fairly rudimentary form is link the quality of their internists via data to the payments that we received. I also think, just sort of building up Sarah's comments, I think the real issue here, we can sort of think about it in maybe three ways. The first is, I think, the schism between our ability to analyze it, so sort of the mechanical and methodological process of crunching the data, and then figuring out what the right questions are to ask. And I think one of the biggest issues is that the people who have each of those skills seldom talk to each other. And so the people who are really, really good at crunching it aren't healthcare people. And the healthcare people don't understand big data. And so there's just this sort of misfiring there. I think the second is the sort of implementation issue. So once we get the results, what do we do? And how do we process it? And how do we handle it? And I think the third is just recognizing that healthcare things look a little bit different, simply because I think privacy concerns. and our concerns about linking data, making them identifiable, and then sort of integrating them into the day-to-day practice of medicine.
So let me make a procedural point at this point. So I don't need to try and anticipate everything that each of you is thinking when you're thinking it. So if you have comments, just hop in here and address what's been said. So it's a dialogue between all of us and not just me trying to stay one step ahead, which I know from past experience is not successful. So if to pick up on your points, Zach, what sense do you have of what is going on in these issues on the other side of the channel? What's going on in France, Switzerland, other places? Do you have a sense of that, or is that?
I don't. I mean, I think it's worth looking at what's been successful, and we can look domestically for that. I think one of the coolest examples is using Google Flu Tracker and Twitter to see where pandemic outbreaks are going to occur. So we essentially took the data on where people were doing searches and see where they were Googling flu-like symptoms, and then we're able to estimate demand for what was going to happen in hospitals around the area. So I think that's a really nice way to sort of bring data together, and that's sort of hugely.
Is it really big data?
Well, I think if you think how many people are
Pretty
searching.
simplistic analysis. Yeah, there are a lot of people searching, but the analysis is just tabulating the number of searches and then looking at them geographically. I mean, so I mean, it gets, I saw when you handed out to us, you said, well, what is big data anyway?
Right.
And I tweeted, the first thing I tweeted, why come no one's retweeting me? At HMK Yale. I would expect to get a lot of followers.
Here we go.
But I said, like, big data is not a size, it's like a state of mind. You know, the question is whether you're just aggregating larger amounts of data or whether you're thinking about it in more complex ways. A lot of our methods are wholly reductionist. They force us to contort our research question to answer something very narrow. I mean, it's good to leverage things like Google and Twitter, but the question is, are we recognizing the complexity of the data? And to me, that's about the interaction. So it's much more akin to systems biology, where people talk about emergent phenomenon, that you can't just look at the components and understand what the output's going to be. You've got to be able to understand the way in which everything's reflecting on everything else. In biological systems, that's how it works. I mean, you can't just say, with few exceptions, you can't really just say, I can track this biological system to get to this output. It's a matter of how things are all interacting with themselves, and there's so many different feedback loops that you can't possibly understand them in a very simplistic manner. Yet, when we turn to clinical medicine, our articles are about trying to isolate an individual factor, holding all other factors constant, as if there's no interactions between any of the factors. And so, to me, the big data in the issue about leveraging machine learning and all of this is saying we need help because no person can keep all of this in their head. We need ample enough data, and then I think of it as sort of a mentored machine learning, which is there should be iterative, there should be bidirectional work where there's some machine learning, but then there's some reflections. Doesn't make any sense because either one by themselves probably are inadequate to solve the problems that we need to do, the insights that we need to yield. So for me, this is about, it's a mindset shift. It's not about the idea of how large it is. And it's, are we finally going to acknowledge the complexity of our system? Because that's why so many docs, too, find our literature to be mundane. Like, people are publishing, and it's good for academics because it gets them promoted, but it bears no relationship to what's going on in the real world. So docs can't make much use of it. And finally, it comes out as static articles. So people look at I mean, the whole idea of journals is antiquated. Journals should be about method development. And then we should be creating interactive products of our research so that people can query and customize their questions around a methodology that's building on a data set. But to come out with a static article that was built on data from 5 or 10 years ago and say that's how we should be treating patients with endocarditis, when we're looking at average results, and that's how medicine's taught. It's like, oh, there was an article that came out 5 years ago from Mayo Clinic, and it sounded like some of those patients were like this patient. I mean, it's just nuts.
But I think this is where the big data is going to make a difference. That part of the reason you saw these average treatment effects was that you simply didn't have enough data to talk about what it meant for an individual patient with any degree of precision. And so I think the actual expansion of it allows you to more accurately say, what does this mean for Dan sitting there in the third row? Because we now have the data and enough versions of, hi Dan, some variants of Dan that we can estimate that with precision. But
So there's a lot of stuff in what you said that I want to follow up on. The first is the way I think about big data is the different way in which you can ask questions when you have highly multidimensional data sets. What we mean is many variables that can have complex interactions to affect an outcome. Traditional clinical trials say, I'm going to test the effect of variable X on variable Y. And that's fine as far as it goes, but putting it all together to see what are all the things that affect us. There's a good example of this is David Madigan, the statistics professor at Columbia, ran a project called OMOP, which is about interactions and adverse effects in drugs. What combinations of drugs come up with harmful side effects? They found new side effects that had not been reported or were not known from combinations of drugs. They also found that when you simulate the conditions and tests of clinical experiments, when you have all the data, when you can cheat and find out what the real answer is, and you have all the dimensions, you find that they actually come up with erroneous solutions a lot of the time. 5% p-values give you the right answer at only about half the time. You'd think it would be 1 in 20. That's not actually what a p-value means, but they're wrong half the time. Studies show that. Usually studies, in fact, don't show that unless you carefully look at them to make sure that they were properly conducted and had sounder statistical methodology. So I think big data, if you have all the information about many individuals, you are able to ask questions that build models about the interactions between variables all at once. What variables actually matter instead of just how does this variable affect that variable. The other thing that you mentioned was, okay, so you have this research paper and it's static. How do you apply it to practice? That's actually precisely what my startup does.
What's your?
It's called MetaMed, M-E-T-A-M-E-D. So we have people who come to us with unsolved medical problems, medical mysteries, chronic illnesses that they've been to doctors and it hasn't worked. And we go through the records. We have a doctor do a detailed medical intake, 3-hour interview, and we look through the research literature. What is actually evidence-based medicine that applies to their case? What has the best experimental results for them? And we actually build a statistical model that has, it's a Bayes-net. It's, this thing causes this symptom such percent of the time. We got that from a study. This thing is a risk factor for this disease. Do you have it? Don't you? You fill in the individual's information, and you can computationally infer probabilistic differential diagnosis. What would happen if you did this instead? What's the odds that it would make you better? It's an approximation, but it's a way of formalizing and bringing into practice and personalizing for the individual the vast quantity of information that's lying there, locked in research papers that would ordinarily only get to you if your doctor happened to have the time to do a lit review himself. Sometimes that happens.
How much does it cost?
That's the question. On an average case is $20,000. We're working towards doing something that's more of a mass.
So it better be a cure.
Sometimes it is. Sometimes it is.
So Paul, sitting from the practitioner's point of view, how's all this sound? You ready to sign up?
Perfect. Yeah.
Well, I'm not ready to sign up yet. I mean, I sound like a little bit of a curmudgeon here, but I think the practical realities actually have been touched on. One is just the operational impact of this on day-to-day workflow, which I think, as everybody knows, physicians are certainly being driven harder and harder every day, despite maybe the moral hazard or some of the reimbursement issues that people refer to. The reality of it is the day is very busy, and anything that influences the workflow they're particularly not interested in, quite frankly. I think the other point that Harlan raised is a big one, which is the docs really aren't trained in this. I think you have to take a half a step back. At the end of the day, do you want your physician well trained in anatomy and physiology, or do you want him or her to know a little bit more about big data? So when you get into medical school curriculums and training curriculums, the reality of it is there's never any time for anything else. So it's pure medicine all the time. I'm not saying that's necessarily right or wrong, but that's the practical reality. And by the way, when you do your board exams and all that, that's the only questions that they ask you are about endocarditis. They don't ask you about p-values and all that. So the reality of it is that, when you go see your doc, that's what you still want today. So we can't miss that the core transaction in healthcare is still between a doctor and a patient. So I'm not negative on big data. It's just there's a long way to go to get to the bedside.
I think that's changing. So, there's this great book by Emily Oster, who's an economist at UChicago, called Expecting Better. And she goes through pregnancy and she sort of she gets all this advice and she sort of views it as slightly paternalistic. Don't drink when you're pregnant. You can't smoke. all these things that we take as truisms. And what she actually does is goes through the clinical data and all of the best sort of peer-reviewed evidence says, well, of all these myths or all these things that we take as fact, how much of it is actually borne by the data? And it turns out that it's not very much. And I think, I would sort of push back and say, I actually don't want my doctor to be sort of using heuristics to guide my medical process. I would be much more comfortable simply because most of my life is driven by the sort of understanding that data in big numbers is better than one-off observations. I also think that providers aren't going to be the first group that take advantage of big data. I think it's going to be insurers. I think that's the natural group who's going to take advantage of what comes here because
Because we trust them.
well, no, but I think that's the whole point is that they're fueled by profits and not by trust. So I think what's going to happen for them is traditionally they're making money now by contracting well, by doing a good job keeping the books or keeping administrative costs down or negotiating good rates with Paul. I think there's only so much sort of juice you can get from that particular orange, and I think where they're going to start doing well is saying, well, who are the patients on my books who are going to get sick, and how do I intervene before it's something that's very, very costly? And that's where the potential for big data to predict when they're going to get sick and what we can do to intervene really has tremendous potential. And so I think it's going to be sort of...
But I'm guessing they've already got that capability.
I think they already use that capability. I don't think as well as they could, but I think that's where they're starting to go.
But to really be successful doing that, I guess I would ask the question, the whole relationship between the insurer and the patient and even the employer who generally is funding it needs to change. Because, an insurance contract is an annual event. So if you really care about me losing 10 pounds, that's 10, in my case, that's a long period of time. That's more than a year. If you want me to really control my blood pressure, So I think the relationship of that contract is wrong.
Yeah, and I think we can look at the example of who has the best incentives, and it's clearly Kaiser Permanente, which has a purchasing and provider arm all at the same time, and they are the leaders in big data right now. We can look back at what's an example of big data working. Vioxx. It was their databases because they had more than anybody else that picked up some of the early cardiovascular side effects from the drug itself.
No.
You might.
Not really. But
How many Pinocchios am I going to get? No, my understanding was it was their data that was what allowed people to actually dig in and find it.
Anyway, I think that even Kaiser's not really using. If you go to
I don't think they're using it as well as they could,
But anyway, I think the question is how do you make this out, and what's your vision for the future of this, of the use of this? One thing that's interesting is when you look at the way in which medicine is currently practiced. For example, so when people talk about these heuristics, they're really rules of thumb that people are using, and what we see time and time again is that in actual practice, the lowest risk patients tend to get the highest intensity of treatments. If you were to try to create a sensible system, you would think that the justification for high intensity treatments, both with regard to expense and the risk, are most justified on the people whose natural history, whose course without treatment would be the most severe. But docs have this risk treatment paradox. They tend to concentrate the treatments in the patients of the lowest risk, maybe because they're worried about side effects, maybe because they're more comfortable treating people who are less complex. And the idea behind some of this data is illuminating the kind of patterns that are out there and figuring out if you wanted to optimize, how would you do it? I'm a big proponent of patient choice, though, too. And the question is, how do we, one of the things I just tweeted was, if you gave the analytics, would anyone use it? Is the interface problem just as big as the analytics? And you've really got to work on figuring out what's the interface going to be. Because when you say, like, docs don't want to do X, or, we talk about who's going to use it, I think it's an interface problem. Because it should be, I shouldn't know anything about what's under the hood. I shouldn't have to worry about this. I should just be confident that someone's vouching for this. And in my own experience, I should be able to revalidate all the time that what I'm getting is true. But with regard to the messiness under the hood, I shouldn't have to worry about that. It shouldn't be. One of the principal problems with our electronic medical record right now is it is a ton of work for docs. It's a turnoff. It's burning people out because it wasn't built on the interface to be delightful to use. And the big data will fail too unless this is actually making people's jobs more worthwhile. It's enhancing their performance. It's bringing greater satisfaction, and it's delivering better outcomes for patients. And so these are just dimensions that we have to think about. If you want to say where the opportunity is in the future, it's going to be in the analytics, the engines, but it's going to be in the delivery system too. And that, I think, is going to be necessary for it to really end up at the bedside for people to use it. It's not going to be enough to say, I've got this really great thing, but no delivery system. It'd be like saying, I have this really great discovery in the lab, but I have no pill, I have no device. There's nothing that's been approved. You can't really use it easily, only under experimental conditions, and that's not going to drive any dissemination and adoption.
I mean, I think we're conflating two issues. There's one issue which is sort of thinking by numbers, and this idea of using, or having a belief in the power of statistical modeling and statistics in general to believe that that's going to allow me to make better decisions than if I just use my gut instinct. And so this is sort of the Moneyball stuff. And so I think that's one element. I think separate from that is this big data issue, which is how do we use big data to sort of improve the analytics. And I think the first issue, the first order one is in medicine, simply saying we can probably do better than gut instinct. And then from there, it's building on that into this sort of big data.
It's the Paul Bunyan thing. People have to realize they can keep using the axe, but there's this thing called an electric saw.
So Paul, we've talked about providers, we've talked about payers, we've talked a little bit about patients, but tell us about, so when we use these analytic techniques to tell the patient to do something differently or anything at all, how often does the patient actually do what we tell them to do over a long enough period of time to make a difference?
Probably about as often as my teenagers listen to me. Not that often. I think, Harlan probably knows the data better than I, but the rule of thumb that I always use is at best it's half the time they listen to you. So, of course it depends on what the issue is. If it's don't smoke, don't lose weight, or lose weight, whatever.
Lose weight, they listen every time.
I got that one down, right.
Then that's fairly infrequent, quite frankly. You got to remember, you're interacting with a patient for maybe 10, 15, 20 minutes, sometimes slightly longer, and then you leave and go see somebody else, and they leave and get back in the car or whatever and go home. I mean, like, oh, what an impact.
And have a burger.
Yeah, I mean, so they don't listen. The compliance rates are hard, and it's also complicated because patients get elderly. Patients are on 10, 15 meds. It's very hard to be compliant. So generally speaking, it's almost a coin toss.
So unpack it. So this is a question of whose problem is this, ours or theirs? We have a paternalistic system. We put people on 20 meds. Can you believe we actually give someone a prescription for 20 meds and say, yeah, we give them 20 meds sometimes. They don't always take them. It's like we come in and give scripts, and we don't contract with people. Like, we don't have a mutual contract. Hey, let's talk about the options and let's decide together what to do. We come in and tell people what to do. And we're surprised that, take statins, one of the best drugs that we have. At 6 months, only about half of the pills are dispensed that are prescribed for people who are on statins. So at least as a marker, now that doesn't mean just because they got them filled that they even took them. But your best case scenario is they're taking them 50% of the time. But again, we're taught to be paternalistic. We're taught to tell people what to do. We're taught not to engage. We're not taught to engage in any sort of shared decision making. And I say, what's even shared about it? It's the patient's decision. I'm the one that's supposed to be helping them make it's an informed choice that fits their preferences, values, and goals. But the whole question is, how does data feed into that? If you've got a broken system like that, you can feed as much data into it as you want. And it's not fundamentally going to shift the balance of power. It's not fundamentally going to bring people to, is it about following my direction, or is it about us setting a goal together and seeing whether or not I can help the patient reach the goal? The system's not set up for that. And our visits with patients aren't set up for that. We need health educators. We're not trained even to motivational coaching. So where does that fit in this system? And so part of it is, and I think you're right, Zach, it's cultural, and it's about saying, how do you disrupt the whole system, of which the big data's got to feed in as part of it? Because if you disrupt it well, but you don't have good information feeding into it, then that's not going to be helpful. If we improve the quality of the information feeding into it, but we don't fundamentally shift the way in which it's organized, then it's not going to be helpful either. And
So I'm getting really optimistic. I don't know about you guys.
But I'll give you
all about opportunities.
So at this point, we can open this up. You guys can join the dialogue. We're not going to interrupt this dialogue, so you have to fight your way in, but raise your hand and we'll try to recognize you.
But here's the optimism. It's that we've tried putting more pain on patients by making them pay more, and it turns out that didn't work. And what is making a difference, and it's what United is starting to do, which is making them pay more but giving them information in the process. Okay, so it's saying something like, we're going to rank hospitals on quality, we're going to give them star ratings, and we're going to say you're going to pay more for going to a crappy provider. Okay, so you're using the information to say, here's your choice, or you have a choice set, you're making them more exposed to financial risk, and you're giving them information to shape around. And so I think it's those different factors that are
Looks like we have a bunch of questions. Back row.
So you mentioned like a health panel their prescription for losing weight because they actually understand the fundamental reasons why they should do that.
Yeah, see, I think it's a false frame to say, to what extent are you going to follow what I tell you to do? What extent are you going to make me happy? Are you adherent? Are you compliant with my instructions to you? Or have we actually sat down and said, look, for what your situation is, there are several options. And identical people can make different choices and all be right, depending on how it aligns with their preferences and values and goals, what they actually care about. And actually, you may care about money because this is coming out of your pocket. And instead of me saying, ignoring that, no doctor pays any attention to that because, gosh, that would be reprehensible if I paid any attention to money. But if actually for some of my patients, it's a trade-off between what they're going to be able to buy and for their families and pay their mortgages. And like to take that off the table in the discussion is maybe makes me feel good because I can say I treat everyone the same. But it's not to recognize that for individual patients, this can be a dominant consideration. And so am I really the one to tell you, like you are not following my directions by not doing what I'm telling you, when your alignment of values are fundamentally different than what I'm telling you? And it's true that some patients will turn to me and say, tell me what to do. Tell me what you would do. And in that case, I'd say, I can tell you what I would do, but you've got to sit and listen to why I would do it. I do because here's what I'm valuing. This is the choice I would make because I care about X, Y, and Z and not A, B, and C. But we don't, this is why I think it's exciting time, Dick, because I think this is coming. Consumerism, opportunities. Docs have no tools to do this. If I walk into every appointment and implement this, I'm never getting out at the end of the day. I'm by myself. I'm stranded. I've got no one helping me to do this. I've got no pre-work with patients when they're in the waiting room that primes them for this discussion. And everyone who tells me patients don't want to participate, I say that's our fault because we don't put them in a position to do the things that they're naturally doing every day, which is making choices about where they're spending their money. And it's not necessarily about money, but this is their health. And it's up to us to figure this out. This is what you guys should be challenged to think about. What are the disruptive innovations that have fundamentally reshift the way in which we practice? Because I don't think in 10 years we're going to be practicing like we are now, but what's going to be different and how is it going to be better?
Me?
Yes.
Excuse me. So, thanks, Dick. I'm very fascinated by what you're talking about, Harlan, and I was actually having a conversation earlier this week with somebody about instantaneous access to data as it happens, whether it's coming out of the medical practice or out of the hospital, getting into that data, being able to pull real-time information on patient response to medication, on patient interest in medication, on patient outcomes from treatments, medication, devices, whatever, therapies, conversations with physicians. And at the same time, I started thinking, well, how are we going to share that data? Who's going to provide access to it? Who's going to keep it? Who's going to hold it? And how much of it is actually going to be shared and how much of it is actually going to be sold into business for millions and millions of dollars, the way that, businesses like IMS Health have made off of, the pharmacy data and, the insurance data is all. How much of that is actually really going to turn into positive patient outcomes?
Well, the thing I think we should solve tomorrow is, if I were, God forbid, diagnosed with cancer, next week, I want to know as many people who are like me, who were diagnosed with that type of cancer, and what happened to them. Like, why can't that happen? Like, why can't society say, you know what, we have tumor registries, we have cancer, but how come we can't pull it together and say, we're not going to waste another experience with cancer because people are getting treated with every different combination and perturbation. We're going to standardize some very basic minimum data that's collected. And if for every person who's diagnosed, they're going to know the other 100 people like them, including all the contextual information at my education level. Am I this? Match me with people, and I want to know how long did they live and what were they treated with? And why can't we change that?
So that precise thing, I have a good example and a bad example of that I've seen. The good example is, so there's a professor at Rockefeller Institute, Sanford Simon, and his daughter was diagnosed with hepatocellular carcinoma at age 12. And their whole family kicked into gear. He started researching cancer, and she, at the age of 18, got a bunch of patients together with the same rare cancer, got their genotypes, and found the pretty much one mutation that characterized it. And this was a nonprofit. Patients did it because they wanted a better chance at a cure. And that kind of thing actually does help patients. The disappointing thing was that, networking, we encountered a startup that gathers data from oncology wards and tries to find out how treatments are being used, in what works and what doesn't in cancer. And I thought, oh, this is a great opportunity. These people are, brilliant engineers and doctors, and we're going to find out what treatments are most effective in treating cancer and improve the standard of care. No, turns out their business model is to sell to pharma the information about how patients use cancer drugs, but not at all about how well they work. I'm like, seriously, you couldn't throw in trying to cure cancer as a side project or something? No. So you're right that data has the potential to be used to make people healthier, but that doesn't necessarily mean the motive is always there.
Fourth row.
Team-based care, I think, is something that hasn't been mentioned. The challenge of the time constraints on physicians has been talked about a lot. The use of clinical pharmacists, the use of nurse care managers, team-based care in the office, I think holds a lot of promise for, incorporating the values of patients into decision-making, taking more time with them. And I think it's also a construct where we could start to use data to feed new workflows, and we're actually doing that at Coastal up in Rhode Island. We have an analytics platform that's taking claims data and giving us the probability of a patient being admitted to the hospital in the next 12 months. So we can set that at a certain threshold, say 35%, and say, okay, if you're over that, we're going to plug you into a multidisciplinary care conference. It's going to be sort of a pre-visit planning structure, and then we're going to proactively bring these patients in. So I think that it's been interesting, the discussion about data. It's really only valuable if you have all the pieces, right? You're going to do the data analysis, you're going to bring it into something that's actionable, and then you're going to have a workflow that actually works for all the providers, and then you're going to measure the effectiveness of this over time and look at things like, okay, what are our readmission rates, what are our total hospitalization rates for this population? And we actually have that underway, so I actually do feel optimistic. I mean, it's just the beginning and it's far from perfect, but I think this is where it's going, and I think that we can already see that.
Yeah, two quick comments on it. Team-based care, totally agree with this. I think we should be tiering our care to a much greater extent, and big data could help you with that, because if people are staying within the expected bands with a lower level provider, then probably they don't need to escalate up. If they deviate from any sort of expectation, you say, actually, this is not following expectations, we may need to get a higher level provider involved to kind of look at it. With regard to big data, I think this is how I picture this thing together. What I'm seeing in healthcare is that people, and we heard this week at lunch, but I'm hearing it from a lot of different sides, that people are looking more towards solutions than products. Big data by itself is potentially a product, but the solution is better outcomes for patients. That's a complex intervention. So in that stream, the big data is one part of a product that has to fit into a solution. And if you think about it in the solution-based thing, where we're actually, the goal is not to produce the big data, but the goal is to improve the effectiveness and efficiency of healthcare, then it changes the frame on what you're trying to accomplish. And then that's where what you're bringing in, I mean, all these things are kind of saying, what are the models? And I need to invest as much in the models of application as I do in the analytics themselves. I can't neglect either side, or else likely to fail.
And the challenge here is that the payment models and the business models are changing kind of slowly. So to try to undertake this kind of process change is a bit of a gamble. Because you can't really see return on it right away.
This is where people say Paul's world, they say they ride the horse till the horse dies, and the horse is still running, so.
Right. That is the problem. I mean, you're exactly right. The economics are not really favorable for that as they stand today, unless you're in a capitated or...
So what do you do about that? You say, I'm in an institution where we should be innovating, but we're going to lose money if we really innovate and get ahead of the payment model. How do you convince people in your place to say, well, maybe we'll lose money for a couple of years, but we'll make money when I retire?
Well...
or you retire me.
I think the answer to that is we look at it like a portfolio of business. So we have a segment of it which we'll call the capitated business, which would align very similar to what you're describing, where we probably will lose money, if you will, if you look at it at a P&L. But overall, we still have the horse we're riding, the fee-for-service horse that does still pay today, so it keeps the lights on. And ultimately, it's like weaning somebody from a ventilator. You just sort of shift them, and then they're off on their own. So I think this is a multi-year kind of project. And along that path is not only the economics, but just the competencies that you need to build inside the medical infrastructure. The people we need to hire are different than just yet another cardiologist, as beautiful as cardiologists are. The reality of it is we need sort of mathematicians and statisticians and actuaries, and that's the new age of what's evolving inside medical groups and health systems. And so, that's more infrastructure. That's actually more costly. So the costs go up. They don't go down, contrary to what everybody else sort of wants it to be.
Right.
The data does not support that. It's more expensive. I think in time, it will be less expensive, but in the short run, it's more expensive.
So there's some questions over here, unless they've all been answered, in which case we'll go. Jimmy, did you have a question?
Yeah, a quick question. Of the exabytes of data, how much of that's junk? And
It's probably mostly imaging. I mean, it's probably mostly, the imaging work. I mean, so we just got, I have a new database. It's every claim filed by United, Aetna, and Humana since 2007. So I have literally a claim line for everything that's ever been paid for them, and that's 14 terabytes. So that's not nearly as much as what you're talking about.
Is that useful? Or?
Yeah, ask him how much of that is junk.
Yeah, exactly.
How many terabytes you say you have?
It's 14.
14, so 13.
Yeah, exactly.
You got a whole terabyte.
Yeah, exactly.
I'd also be curious just to know your thoughts on new business models around oncology, around that track like Foundation Medicine and what they're doing, and does that fit into big data context?
Let me just don't say, we were kidding about this, but I think it's a matter of how clever you are, right? So any database could actually be total junk. I mean, this has real signal in it. But the question is, what are you using it for? Can you identify questions for which it's ideally suited to answer? He's interested in cost. It's actually ideally suited for that. And so in that case, it's actually all useful. But if you tried to do comparative effectiveness of two medications, it might be more hazardous. So I don't think it's junk or not junk. It's a question of how
what you want to use it for.
How you're framing the question.
Great point. Yes. Here.
Harlan, we don't have a lot of disagreement on what data to even collect, and we're still developing the techniques on how to analyze them. Who do you think is going to make the sort of key breakthroughs to actually get to a solution? Will it be private organizations that will use it for their own competitive advantage? Will it be sort of public-private organizations like NQF? Will it be government efforts like registries, or will it be you?
Well, it could be us, right? I mean, I think that this kind of change occurs. Dick's an expert in this. It's disruptive change that occurs sort of suddenly and unexpectedly because people have a skunk works attitude about it. They're people who aren't constrained by the assumptions of the world around them and are thinking in different directions than everybody else is, and all of a sudden comes up with an idea that can gain traction. I don't think it's going to come out of conventional large bureaucratic organizations. I think it's going to come out of people who are tilting their head a little bit to the side and have a willingness to take risks and want to see this occur in a different way than it has in the past and are passionate about promoting patients and society's interests. And those people will then make strategic partnerships with people who within their own organizations can't find that kind of spark, but when they see it, they want some of it. And I think that that's where it's going to come from. And I think that's why we live in a great era, because in the past it has been more hierarchical. I mean, somebody's had a great idea in the basement, and it's really hard to get it up to the top floor. Now, power's distributed in a different way given the technology that exists, and the power of ideas has never been able to spread faster or more effectively than it has in this era, and bad ideas too. But if you can come up with good ideas, I think it's going to come out of that.
I'm a surgeon, and I'm very interested in data also, and that being said, I think it's very challenging. So I would ask you sort of two questions. One is, how do you wrap your head around the idea of trying to drill down the data? In the sense of, you could say that you have a drug that the data shows is good for men in their 50s. Do you then drill down and say it should be for men who are between the ages of 50 and 52, or only for men who are 50 and who are white or African American? So where could it possibly end? And that being said, to go to your other point, I find it very paradoxical to say that we should follow the patient's values, financial situation, etc., and then have this reliance on data. Because the data could point to this particular treatment, and the patient may say, that doesn't work for me. So what's the point of having all that data if we then also are going to drive by the patient's values?
Okay, so here's the quick thing. So I'll do the second one first. We are informing choice. It's highly effective by definition if you have helped people, equip them with the information that they seek in order to make the decisions that they want. If just because they choose against what on average would be the best effect, or even what would produce the best survival because they don't value whatever it takes to do it, doesn't mean they've made a wrong decision or the data have been useless. In fact, it validates the importance of the data to making sure they've made as informed choice as possible. It's up to us not to overwhelm them with information, but to give them whatever the critical pieces. With regard to the idea about how much do you drill down, this gets to this issue of certainty and another pivot that needs to occur in medicine, which is we're in a frequentist universe where people are depending on p-values. What's the likelihood this is true or not? Rather than a Bayesian construct where you're basically saying this is 20% likely to be true, or this is 20%, this is 50% likely to help you. I mean, this is the real world. For everyone, it's probabilistic mostly. It's not deterministic. I can't tell you if I give you this pill, you're going to benefit. Often I'm saying I'll give you this pill and the number needed to treat is 50. 50 people like you might have to take this pill to benefit if I've even gotten down to the proper estimates. And so I think we need to think about the information flowing into medicine less as discrete numbers and more like heat maps, and more about gradations of risk, and giving people the information they need to make the right choices. Because I think, again, in an education system where I'm learning about mechanism, I'm thinking very deterministically. Does this work in 50-year-olds? Whether, as opposed to, do I have any degree of belief that it's more likely to help this person than that person? How much confidence do I have about that? And then that uncertainty's got to feed into your decision. And we need to help patients understand how we communicate that, because that's real, as opposed to this artifice of walking in, and I know you're a surgeon, but this certainty that often surrounds certain fields in medicine, where you say, this is what you need. But actually, if you go to come in on Wednesday, somebody else would have said the exact certainty, something else. And we need to populate it with the estimates that we know are deriving from the data.
But if I could just follow up, I'm sorry. This is such a fascinating topic, I think. So you want to inform choice, but we're talking about overall the bill of healthcare in our country and around the world. So we have all the data that says that this treatment for cancer works. And I say to you, it doesn't work for me, I don't want that. And we've had a discussion, and I say no. But then 6 months later, I get really sick. And then I go to the ER, or I go to the hospital, I get admitted, and now the bill is 3 times or 10 times as large as what it would have been. So can we as a society afford to allow that kind of choice in the face of the big data? So, we know that a treatment
look, I mean, my feeling is that people have agency over their own bodies, and we've got so much other waste in the system. Before we start constraining people's rights around their own body, we would have to, I think, get rid of all the other waste, and that's going to keep us busy for a long time. It's too big an issue to force people. Now, that being said, I think there's inbounds and out-of-bounds things. I mean, there's stuff that really has no proof and is highly expensive that you would say, if you can pay for it yourself, okay, but we're not going to pay for that. But with regard to people refusing to go with what on average, or what for them might be the thing that would optimize their life expectancy rather than some other things, I think you've got to be able to yield to people's way that they're valuing. It's essentially, in economic terms, it's the utilities. And its utility weighting for each individual is going to be different. How do I weight stroke, bleeding? How do I rate the cost? How do I rate the inconvenience? How do I rate the nausea that I'm going to get with the chemotherapy? You know, all those things are going to be part of what people's just, where am I in my life? You know, all those things are going to be important.
One last question.
So I just want to respond to Paul's point that people are not ready to sign on yet, and to Harlan's point that somebody has to take the risk, right? So one of my current clients is the third largest health plans in the US, and they are doing a 20 million upgrade in their infrastructure, okay? And then we are trying hard to tell them invest at least 1 million in big data and analytics, and they don't want to do that. So I think
informed choice, right?
Yeah. So
even though that's good for them.
Insurance companies are the ones who will be the drivers of it, but I think based on my experience that they are not there yet. Right? People are not ready to sign on yet, and I think it's not because of the willingness to take the risk. I think it's because of they have not seen a tangible value.
They don't see the ROI on it.
But the difference
ROI on that yet, and I don't know when I'm going to see an ROI.
But the issue here is I think companies say, I need to invest in big data. And I think that's sort of a ludicrous way to view it. The question is, what can big data do? You know, and so it's like saying, I'd like to invest in hammers. You know, if you're interested in driving nails, that's a good investment. If you just want to chop down a tree, it's probably not sensible. And so I think the question is, what for this company can big data do? And I think this is where there's a schism between what are the questions that we should be asking and how do we use the tools at our disposal to answer those questions. And too often we view big data as sort of an entity of itself as opposed to a tool for answering a particular question.
That's a fantastic summary, Zach. Thank you very much. We're at the bewitching hour. Thank you for attending. I hope you've gotten some of your questions answered. I'm sure we'll be standing around for a few minutes afterwards, so if you want to come up and say hello, that would be great. Thank you all for attending. We've enjoyed having you. Fantastic, fantastic.
Reception at the Beinecke Terrace, so.
Thanks. Clara, thank you very much.
I think what this was teaching me was it's hard to talk about out of context.
Bonnie, do you ever meet a scene?
That's why the minutes is joking around. For you, actually, it's
I think the price of everything paid for in this country. Like for you think it's ridiculous.
Hey, thanks for your question. That's
Great, thanks. Hey, Dick.
Yeah, hey, how are you? Good to see you. Right, good to see you. Great question, great follow-up question. Yeah, right.
Really interesting stuff.
Yeah.
Yeah, that's where it's all at. How are you?
It is good. Yeah. We ought to get together and catch up or something.
Yeah, for sure.
Yeah.
For sure.
That would be great.
Yeah. How long are you here? Up here?
So I'm generally here 3 days a week. I'm generally here most of Wednesday through most of Friday. So yeah, so it's great. Yeah.
And Kevin was so helpful. Thank you so much.
That's really great. Yeah, that's terrific.
I think we've got some good news on the IP front from the hospital. So
there's been an interesting correspondence going back and forth. Yeah, it's great. Well, it's a really interesting question about what is the level of detail at which this data is gathered, right?
Because I think about what I do, spine surgery. I mean, they say, well, you should do the fusion in males who weigh between 190 and 200 pounds, and who are 6 foot tall, but not someone who's 5 foot 10, and has the BMI, right? You can just keep going.
Right, you can.
Where does it end?
Right. No,
and when does it become impractical or too bulky?
I thought Harlan had some great things to say here.
Oh yeah, really amazing.
I don't want to interrupt. I just want to say thank you. I'm not leaving. I just wanted to say thank you. Right.
So may I follow up on